the people who are joining us in webinar number 163 since the Andean Health Organization, equally to NANO Agreement, started a cycle of webinars in May of 2020. To begin, we will give two key messages. First, the COVID-19 pandemic has caused a major setback in regular vaccination in our countries, which has increased the risk to recurrence and outbreaks of dangerous vaccine-preventable diseases. The pandemic has taught us a lesson in terms of the relevance of strengthening health systems and developing all relevant strategies to ensure the vaccination of all people throughout their life course. And the second message is that the COVID-19 pandemic teaches us that the capacities built and strengthened in these 3 years should not be rolled back. Research, epidemiological and genomic surveillance, vaccine and drug development, deployment of prevention measures, and good communication remain fundamental for a caring society. Under this premise, Orasconu is very clear about its coordinating role and continues to open dialogues and intervention with the participation of all sectors to ensure a dignified life for the inhabitants of our country. Reflections on these and other priorities relevant to health and well-being can be found in the monthly Noti Salud Andinas newsletter, available on the website of the Andean Health Organization. Accordingly, today, Thursday, March 16, we open our virtual doors to discuss a topic of great importance for our region with the webinar number 165, titled COVID-19 and Long-Term Symptoms. We invite you to leave your name, organization, and country from which you're joining us through the comment box of the Facebook Live or YouTube Live chat. In that same space, you can leave your questions or send them via email to webinarshorasconu@gmail.com. To access the certificate of attendance to this webinar, as usual, you must fill out a short survey and leave your data in the fixed link found in the Facebook Live or YouTube Live chats. The certificate will be sent to your email in the next few days. This webinar will be developed with the usual dynamics. We'll start with the institutional greeting, then the presentations of our excellent speakers, the active pause, and the space for Q&A. To begin this important day, I give the floor to Dr. Maria del Carmen Calle, Executive Secretary of the Andean Health Organization, who will give the welcome and institutional greeting. Go ahead, Dr. Maria del Carmen. Thank you, Lucho. Well, when we say 163, we'll not consider the two webinars with Rotary International. When we say 165, we consider those of Rotary International. So I will stay with 163 for now. Welcome to participate in webinar number 163, which aims to publicize the progress made in public health worldwide on the most relevant and topical issues, seeking to provide access to knowledge and education from the most operational levels to the decision makers of the ministries of health and institutions and the interested public. Today's topic will seek to raise awareness and strengthen knowledge about COVID-19 and its complications. During the first year of the SARS-CoV-2 pandemic, an increasing number of cases were registered who, after having had COVID-19, were left with persistent symptoms, which made it evident that not only the respiratory system was affected, but also the cardiovascular,
sistema nervioso,
nervous
efectos
system, and
psicológicos,
psychological
los
effects,
cuales eran
which were
independientes de la gravedad de la
independent of the
infección,
severity of the infection,
siendo más frecuentes
being more
en las
frequent
mujeres,
in women,
personas de mediana edad
middle-aged
y en
people,
los
and in
ancianos,
those who
más
initially show
afectadas
more
inicialmente.
symptoms.
Según un informe publicado en
According
febrero
to
de
a report
2020
published
por
on
el
July
Centro para el
2020
Control y la
by the
Prevención,
Centers for Disease
al
Control and
menos
Prevention, the
20%
CDC,
de las
20%
personas
of
entre
people
18 y
aged
34
18 to
años
34
que tuvieron COVID por
who had
primera vez
COVID-19
y
for the
no
first time
fueron
and were not
hospitalizados
hospitalized
tuvieron
had
síntomas persistentes
persistent
de 2 a
symptoms
3
2
semanas
to 3 weeks
después de haber dado
after testing
positivo en
positive
una
for
prueba de detección de
uh,
coronavirus.
coronavirus
Por otro
detection
lado,
test.
un grupo de
On
investigadores
the other
suizos
hand, a group of Swedish
descubrió que
researchers found that
26% de
26%
los
of
profesionales de
young
la
health
salud jóvenes
professionals
que habían
who
estado
had been
sanos
healthy
antes de
before
presentar
having mild
síntomas de
cases of
COVID
COVID-19
presentaron por lo
had at
menos un
least one
síntoma
moderate
moderado o
or
grave
severe symptom
durante un mínimo de
or at
2
least
meses después de la
2
infección,
months after the
mientras que el
infection, while
11% presentó al
11%
menos un
had
síntoma
at least
previo
one
8
symptom
meses.
that lasted for 8 months.
Un paso especial para
An essential
identificar
step in
los
standardizing
criterios y
criteria
para llevar a cabo
for
las
conducting
investigaciones y los
investigations and
tratamientos
treatments
puede establecer
was
una
to establish
definición de caso
a
o
WHO
DPS, la
case
misma que se establece
definition, which
con
is described as
la afección post-COVID. Se produce
post-COVID-19
en
illness
individuos
and
con
occurs in
antecedentes de
individuals
infección
with a history of
probable y
probable or
confirmada
confirmed
por el SARS-CoV-2,
SARS-CoV-2 infection,
generalmente 3
usually
meses
3 months
después de la
after
persona
the
de
onset of
COVID-19,
COVID-19,
con síntomas que
with
duran al
symptoms
menos
lasting at
2
least two
meses
months
y que no
that
pueden
cannot be
explicarse
explained
por un
by
diagnóstico
an
alternativo.
alternative diagnosis.
Los síntomas más
The
comunes
most
son
common
la
symptoms are
fatiga,
fatigue,
la dificultad para
shortness of
respirar
breath,
y la
and
disfunción cognitiva.
cognitive dysfunction.
Pero también se pueden dar
But
otros
other symptoms
síntomas
may
que
also
pueden
occur and
repercutir
often
en el
impact on
funcionamiento
the
diario
patient's
del enfermo.
day-to-day functioning.
Los síntomas pueden ser de
Symptoms
nueva
may be
aparición
of
tras
new
la
onset
recuperación
following
inicial
initial
de la
recovery from an acute
infección de
episode of
COVID-19
COVID-19,
o pueden
or may
persistir desde el
persist
inicio
from
de
the
la
onset
enfermedad.
of the disease.
Los síntomas también pueden
Symptoms may
fluctuar
also
y
fluctuate,
puede haber
or there may
recaídas
be
en el
relapses
tiempo.
over time.
Para los niños
For
puede ser
children,
aplicable
another definition may
otra
be
definición.
applicable.
Se sigue aprendiendo sobre la
We
evolución de
continue
esta
learning
enfermedad.
about the evolution of this
Sin
disease.
embargo, existen
However,
muchas
there are many
interrogantes
questions
para explicar
to
por
explain
qué hay
why
pacientes que
there are
tienen
patients
COVID
who have prolonged
prolongado
COVID and
y
others
otros
do
no.
not.
¿Se trata de la
Is it
persistencia
viral
viral o
persistence,
hay
or is
microtrombosis
there
que rodean al
microthrombosis or
sistema
some problem with
vascular?
the vascular system,
¿O hay problemas
or
de
is there
autoinmunidad?
autoimmune
¿O es el sistema
issues,
inmunológico
or
que
it
está
is the immune system that is
descontrolado y está
malfunctioning and
causando
causing some of the
la enfermedad?
symptoms?
La condición
The
post-COVID-19
post-COVID-19 condition,
(PCC),
PCC,
nombre
the
oficial
official name
usado por la
adopted by
OMS,
WHO,
se torna en un
is
grave
becoming
problema
a serious public
público
health problem
debido a las
due to the
complicaciones y
complications
secuelas
and
de
sequelae of
COVID-19,
COVID-19,
como los efectos
such as
pulmonares,
pulmonary,
cardiovasculares,
cardiovascular, neurological,
neurológicos, físicos y
physical, and
mentales,
mental
por lo que
effects.
las autoridades de salud
So
de
the health
Andes,
authorities of
unidos
the Andean
y de
Ministries of
Orasconu
Health and the
siguen
Orasconu
coordinando a
continue
fin que se
to
conozca
coordinate in order
la
to
verdadera
know
magnitud
the
del
true
problema
magnitude of the
y se
problem
mejoren
and
las
improve
medidas para
measures
su
for
diagnóstico,
diagnosis,
prevención y
prevention,
control.
and control.
El CDC llevó a cabo el estudio
The
Condiciones
CDC
Básicas
carried out the
de
study
sobrevivientes
post-COVID conditions
adultos de
among adult
COVID-19 de
survivors
18 a 64 años y
of
mayores
18
de
to 64
65 en
years and
Estados
over
Unidos
the age of
con
65 in the
comorbilidades
US and was
cognitivas
published in May of
y describe
2022
que los
and
sobrevivientes de
describes
COVID
the COVID
tienen el doble
survivors
de riesgo
have
de
the
desarrollar
double
embolia
the risk of
pulmonar
developing
o
pulmonary
enfermedades
embolisms
respiratorias.
or respiratory
Uno de
conditions.
cada 5
One
sobrevivientes
out
de
of
COVID
five
de
survivors of
18 a
COVID-19
64
from 18
y
to
uno de
64,
cada
and
4
one out of four
mayores mayores de
survivors of
65
COVID over the age of 16
experimentó al menos una
presented at
condición
least
incidente que
one
podría
condition
atribuirse
that may be attributed to a previous COVID. In order to present the progress achieved in the post-COVID-19 condition, we have invited prestigious researchers from two important universities in the US, Dr. Cameron R. Wolf and Dr. Cristina Barkauskas from Duke University, Dr. Leonardo Tamariz and Dr. Ana Palacio from the University of Miami. Welcome. Thank you very much, dear Dr. Kai. After the greeting of our Executive Secretary, introduce myself. My name is Luis Bengolea More, Medical Epidemiologist, Coordinator of Health on Borders and Thematic Areas, and today, with great pleasure, I will be in charge of moderating this webinar. After this preamble, we will start this event by giving a warm welcome to Dr. Cameron R. Wolf. Dr. Cameron is an Associate Professor of Infectious Diseases at Duke University. He was co-chair of the Duke University COVID Task Force that assisted with all the elements of infection control, treatment, and public mitigation for the hospital and university. On the research front, Dr. Cameron has been an active member of several NIH trial treatment teams and is a member of the NIH COVID-19 Guidelines Committee. He is a transplant infectious disease clinician specializing in the care of immunosuppressed patients and those living with HIV. Welcome there, Dr. Cameron Wolf. You have the space to present the COVID-19 treatment, vaccines, and the impact of new variants. Go ahead, please.
Hey, thank you so much for the introduction. This is a real thrill to me and a pleasure to be able to speak to you all. I'm sorry, my Spanish is not good enough to do this without the assistance of an interpreter, so please bear with me on that front. Let me just share my screen. I think you should be able to see that now if I can get some nods of the heads. Can people see that? Yeah, perfect. Hey, I'm going to do what I think is a lead-in to the conversation of long COVID. I'm intentionally going to try and speak more to the trends that I see in terms of COVID in general, and hopefully that'll be a good lead-in to my colleagues. I do have some disclosures. I work with some companies that have been in the COVID space, but I don't plan to talk about their work, and any mention of my thoughts here is not representative of what the NIH Guidelines Committee thinks, although they may be in line. So, I want to start from a global perspective. I would say that we are in a far better place than where we have come for much of the last 2 or 3 years. This is US representative data. On the left, you see really a flattening of a curve in terms of overall case burden within the United States, with some small surges that have come as we've gone through a number of different evolutionary waves. But critically, compared to that mortality graph that you see in the bottom left-hand corner, the last 12 months have been relatively controlled compared to where we were earlier in the pandemic, with certainly less impact on our hospital, less impact in our intensive care, and ultimately less impact on mortality. We're obviously going to use this webinar to talk about morbidity, however, and long COVID clearly still plays a major role there, as we'll get into. Much of this in the US, I think now fundamentally comes down to vaccination. And like it sounds from the introduction, that still occurs in many parts of the world. We have had wide regional variation in vaccination. We're on the far Atlantic coast here in North Carolina, and our vaccination rates have tended to sit around 60 to 70%, far from ideal, but far better than where we had been. Part of the challenge has been these sorts of maps to try and keep up with where the virus has moved. And I think, as I take a number of examples here of countries represented on this call and compare them to the US, actually the striking thing you see is how similar these graphs would appear. As we move from left to right on these graphs, we move into really in the purple phase and then into blue and pink into an Omicron wave. And that has corresponded with a flattening of those curves in terms of mortality. The pink and purple that you see on the far end is representative of what is now occurring widespread across the world. And while there may be subtle differences, this is the recombinant XBB variant now starting to become dominant, certainly in the United States. And some of the Omicron subvariants, in particular, one termed BQ. And why I put this here is to represent a couple of things. We expect this variation in variants to continue to occur. That's a natural evolutionary pressure that's going to be seen. But it is important to represent that for probably a couple of reasons, things have become much more peaceful. One, as I'm going to get into, we're much better vaccinated and naturally immune in many people's situations. But two, there has been a drift towards less pathogenicity as we've got further down the road with more advanced variants. Here, at least, I think in the US, this graph is probably pretty representative of where many of your countries would also sit. This is the dark blue second column is representative from about 7 or 8 months ago, showing that on average, we're getting to about 70-75% vaccine uptake. But if you then add on natural infection to that, in fact, we're well into the high 90s of people in the community that will have strong, robust anti-spike antibodies, some form of developed immunity. And the further we've actually gone along here, I think the data is stronger that actually natural immunity is holding up quite well. Prior infection maybe not quite match vaccine-related defense, but certainly additive to it. And on the whole, this is providing really robust defense against the severe cases of COVID that we certainly saw washing through our communities in 2020 and 2021. It's not been so perfect to prevent infection breakthrough in general. And maybe some of the later speakers will talk to what that still means in terms of long COVID risk moving forward, but certainly robust community immunity now that has led to really good defense against severe cases. Perhaps appropriately, I think many countries have targeted vaccination strata based on, based on age. That's appropriate. That's where we've seen our significant rates of mortality still. I cut out a slide here that talked about age demographics to Omicron mortality. But an important feature of that was that still it's heavily represented mortality in those over 75. And that's contemporaneous data from 2022 and 2023, where the rates per 100,000, if you're less than 50, would be less than 1 in the United States at this point for mortality, whereas the rates in over 75-year-olds would still be more than 500 per 100,000. So a significant age-related jump that still occurs. And so we've targeted vaccinations accordingly to those who are older. And you can see from this graph, particularly in the left, in the dark purple, we've nationally done a very good job at vaccinating our older adults, over those over 65. Probably less accurate with bivalent vaccines. There's been no part of the United States where uptake of that has been particularly efficient. Although, as I'll get into, I think we could probably do a better job there. So apologies for a busy slide, but I'm going to carve it up for you. So where we're headed with vaccines in the US is certainly towards now an iterative process similar to what we do with flu, where we try intentionally to update variants that are included in a vaccine. As you may be aware, the most recent ones released here have included specific late-stage Omicron variants, BA4 and BA5. And critically, on the graph on the left, you can see that even if you've had previous infection, as many citizens here have, and even if you were previously vaccinated, you get an order of 10 magnifold increase in your antibody response in relation to a bivalent vaccine. So still, even at this point, a booster that can really quite prominently increase people's antibody defense. And in particular, it's relevant against all Omicron strains. So even as variants have drifted further away from early Omicron variants that we saw 12 months ago, the current bivalent booster has actually produced quite wide activity and defense. So if you look on the bottom, you'll see that as each of the histogram columns represent different subvariants of Omicron, in fact, compared to the top graph, which was the old historical booster, orders of magnitude different improvement in vaccine response by updating the vaccine. So this is going to be the trend in the US, I think, moving forward. It's currently being debated by the FDA as to say, how frequently might we need to update the variants included in the recipe. But I think we have a very strong expectation that this will probably come down to yearly. The reason you might think is, well, hang on, if I showed you to start with a mortality graph that had really faded away, do we need to keep worrying about vaccines? And I'll say yes for two reasons. Number one, here on the screen, you see still mortality differences in Omicron. So this is contemporaneous strains of the virus, where the black line represents unvaccinated individuals last year, and the blue and green represents vaccinated individuals. A huge drop-off still, even to this day, for people who have been vaccinated. The public health challenge, I think, lies with the difference between the blue and the green. You could look at this and say you're getting a 50% reduction in mortality as an older adult, for example, if you take a bivalent updated booster. But the difference is proportionally actually really small. So from a public health intervention point, we're taking this on board and saying, maybe we should focus now our updated vaccines, particularly on those at higher risk. So you'll see many US institutions taking away their vaccine requirements for younger, healthier adults. We've done that on the campus here and plan to do that in the health system, and really focusing in on older adults where their pace of losing their immunity is greater as they get older and their risk of getting bad outcomes remains high. And so probably where the CDC is going is, FDA here in the US is what you see on the screen. This will be a yearly boost for us, for older adults for COVID on the left, and maybe a little more frequent for those who are immunosuppressed. And this will be a modified vaccine each year like we do every year with flu. In fact, hopefully actually incorporated into the same vaccine, so you only need one needle. So I'm going to move to one more final thing on vaccines before I move on to some treatments. Early on, I think there was a lot of healthy debate about saying, how do we best measure your protection? And we, in fact, tied ourselves into some knots, I think, early on when people started to recognize that breakthrough infections were still very possible in people with COVID vaccinations, but the severity fell away. And so we started getting into a lot of debates about, well, hang on, what's the real benefit here if you're still getting infected? And how do we measure that? Actually, the measurement has proven to be pretty straightforward. And in fact, your antibody titer, the amount of antibodies that you make, is in fact directly related to your risk of a breakthrough infection. Probably shouldn't surprise us. This is exactly the same with influenza. What you can see, the blue and the light blue and the purple graph, are in fact some vaccines just do this better. The mRNA vaccines have tended to do a very good job at making good antibody supply. That's Moderna in the purple and Novavax actually in the blue. Some of the viral mediated vaccines slightly less effective in the end, I think. So we've seen this variant drift though, and that's got other implications. It's got implications in terms of infectivity, pathogenicity, so how much it makes you sick, and also whether it evades vaccines at some point in the future. And so I'll drag people's attention to the bottom left graph, which really talks about with some of the more recent vaccines, including XBB, the one that's now present most dominantly in the United States. In fact, your antibodies that you would have made to previous infection or vaccination have far less impact. And so I think it speaks to this idea to continue, we will have to continue to modify our vaccines moving forward. The top right table talks about another factor that I think we will want to watch really closely, which is that as variants have evolved, some of them have actually gained a much greater affinity to the cells, can invade more quickly, can become more infectious and contagious. And yet, fortunately, they've not become more severe. And I don't see a horizon where that's likely, but obviously that would be a major change should that take place. So I'm going to end with a little pivot towards some treatments. There's a lot of treatments I could talk about. I've just picked out a few here that I think are topical. The first debate, which I think in my mind is now closed and probably has been closed for a while, is whether a few of our sort of reformatted drugs proved to be effective. And there was, for good reason, a lot of hope that I think ivermectin, fluvoxamine, you could add metformin to this list, would be effective for mild outpatients with COVID. They are cheap, they are available drugs, they are in most countries, and yet I don't think there's any substantive data to suggest that they work. And these here are two presented recently NIH trials that looked at a large US-centric outpatient sort of rigorous blinded trial, and they just didn't curve ultimate increases in severity related to COVID. So I think these drugs should not be sort of in our formularies moving forward. One that I don't know it's effective or not is interferon, and this is interesting because this is a recent publication in the New England Journal. It was a trial heavily based out of Brazil, and you would look at the the absolute risk reduction that you see on the left, and this is for people coming in with early COVID who need to be hospitalized, a substantial reduction in hospitalization risk. And yet the FDA here chose not to review this. Partly, I think, because they struggled with the overview of what was happening in the Brazilian sites running the trial, not necessarily that the drug didn't work. So I truly don't know if this will be an effective therapy down the road. It's appealing to think that just one dose of a little injection can protect someone from severe COVID or other problems associated with it. But the FDA has felt that this was not rigorous enough, should I say. So this remains unknown to me. What is known, I think we can get into the approved antivirals. I'll start with molnupiravir. This drug probably has modest benefit, I would say, in terms of prevention of severity, but it has appeals to me for other reasons. The table on the right shows its effect, in fact, on multiple other viruses. This was a drug designed originally for Eastern and Western equine encephalitis. And yet, as you can see from that selectivity index, the higher the number, the more effective in the lab it is. It's actually quite an active drug against all manner of other viruses because of the way it works. So I would like to think some of our learned experience of this drug, in fact, leaves us with an armamentarium for future use that could be helpful for further pandemics. And similarly, now a large retrospective pragmatic UK cohort showed in vaccinated people, so these are people who should be doing okay anyway. In fact, when they were given molnupiravir, not only did they generally not get sick enough to be in the hospital, but they had earlier symptom resolution. They didn't look in this trial towards long COVID prevention. Some antiviral trials are now starting to do that, but they did show an earlier resolution in symptoms. And I think anyone who's been badly symptomatic with COVID these days, 24 to 36 hours is a meaningful help to that person. Similarly, even in the most severely unwell individuals, so here's a European cohort in preprint. These are bone marrow hematologic malignancy cohort where they compared molnupiravir use against nirmatrelvir, so Paxlovid, and in fact basically came out exactly the same. Whichever the graph was, whilst most people did fine, these were only mildly unwell people, you can see those Kaplan-Meier curves for either of those two drugs really overlapping, which I think supports overall the use of this product. It certainly has no drug interactions compared to folks with Paxlovid, but probably still slightly lower on the efficacy, but not by much. Paxlovid or nirmatrelvir, sorry to be tongue-tied, is widely approved and used in the United States, probably as a largely first-line tablet with good reason. It was based on outpatient data pre-vaccine that was showing it was very effective. Question's always been, what does that mean on a vaccinated population or with Omicron, which is less severe? We have some data to that. This is a pragmatic collection of Californian patients through the Kaiser Foundation, and the red box highlights that these were people who were heavily vaccinated and also pretty sick in terms of the number of comorbidities that they had. You can see in the red text that there was an almost 90% reduction in ultimate hospitalization in this cohort. So I think what it tells me is for the right patient who's high risk enough to develop further complications, some of these oral antivirals are still very appropriate. They're probably not worth quite as much for someone who's otherwise going to do fine anyway. Obviously, the challenge with nirmatrelvir is significant drug interactions. Anyone who's worked in the HIV space can look at this graph and be totally familiar with ritonavir causing us a bunch of headaches. That's likely to continue. Otherwise, though, a very effective drug and appropriately used first line for most patients here who are outpatients in the United States. The other drug, just to mention briefly, it was remdesivir. It's an infusion, so it comes with immense logistical challenges for most centers. It's expensive, and it has good data to support its inpatient use, but I would argue now it has just as good data to support its outpatient use. Here you see an 87% reduction in ultimate hospitalization for outpatients. And so we tend to reserve this product for folk who are really worried about their progression risk, even in Omicron. They have drug interactions that make Paxlovid unfavorable. And I think it's probably a better drug than molnupiravir, but it comes with a major cost. And so I think from a sort of a resource consumption point of view, may be viewed in a very different and probably less favorable light. I'm going to skip through inpatient therapy because I'm not sure that it's quite where we want to go here. Suffice to say that I think from a drug horizon point of view, there's been immense work done on the research front to try and come up with other antivirals that will be effective as both outpatient and inpatient therapeutics. And I've listed some of the ones walking through the pipeline here. The challenge, I think, for all of these drugs is that we no longer have a pandemic of people in hospitals. We have a pandemic of sort of mild to moderately impacted people. And so how these drugs prove that they're more effective than just placebo is going to be a major challenge, and probably one that I think most will be unable to overcome. But it's not to say that we haven't had great development of a number of new therapeutics, which probably, honestly, for future pandemics will help us immensely. So I'm going to end with a little summary and then hand over to people to really dive in on long COVID. Where are we headed? I think it's in a good direction. We have markedly lower hospitalization and death rates. We continue to have lots of infection, probably more than we ever measure. And they are with variants that I would continue to expect to emerge. And yet I have no current visibility of reasons to think why emerging variants will ultimately be more severe. In fact, it's onto a population that is now heavily immunized or natively infected, and I think that helps. We're in a better place because we have a lot of other therapeutic options to treat people with, at least for their acute infection. Whether they work in terms of long COVID prevention, I think remains to be seen. And with that, I actually will probably ask for questions or to turn it over to colleagues. And I appreciate the translation in the background.
Muchas gracias, estimado Dr. Wolf. Ha sido una excelente presentación.
Thank you very much, Dr. Wolf. And I think it's important to summarize some things you mentioned, like when you measure about the public health measure that make the change was to establish the use by age groups, especially giving the older age groups. And the other important aspect was that we have an important tool with the new bivalent vaccines that use BA4 and BA5 Omicron subvariant and have allowed to have a tenfold strength in immunogenicity for people, who also suggest to be used in the elderly. And finally, you've mentioned about several new drugs that are being used with different results, some of them quite good, such as the use of molnupiravir, the use of nirmatrelvir, and with ritonavir and remdesivir. Thank you very much, Dr. Wolf, for your presentation. We invite you to stay in the room for the Q&A. Thank you very much.
Of course, you're welcome.
Now we welcome Dr. Cristina Barkauskas. Dr. Cristina is an assistant professor of medicine in the Division of Pulmonary Allergy and Critical Care at Duke University. He's a physician scientist and clinical trialist with extensive experience in the management of hospitalized patients with COVID-19. She was the site principal investigator for Active3, an NIH-sponsored platform trial designed to study the effects of various antiviral agents, monoclonal antibodies, on the recovery of hospitalized patients with COVID-19. She was the principal investigator and steering committee member of a trial to test the effects of mesenchymal stromal cells in the treatment of patients with acute respiratory distress syndrome, secondary to COVID-19. He was co-chair of Active3B, TESICO, an NIH-sponsored trial designed to evaluate vasoactive intestinal peptide in patients hospitalized with respiratory failure due to COVID-19. He is currently chair of a strategy trial studying immune modulation in hospitalized patients with COVID-19 that is being developed within a new international network entitled STRIVE, Strategies and Treatments for Respiratory Infections and Viral Emergencies. Dr. Barkauskas is also participating in NIH-sponsored Recover clinical trial initiatives to test interventions to help patients with prolonged COVID. Dear Dr. Cristina Barkauskas, welcome. And you will talk about what do we know about long COVID, most common symptoms and treatments. You have the floor, doctor.
Thank you very much for that introduction. That was very kind. I'm going to share my screen now. I hope everybody can see this. I'm excited to be here today. It's a great group, and I think we all have complementary things to share that hopefully will be helpful as your group figures out how to navigate this difficult landscape. Today, I would like to talk about post-COVID phenotypes. So the common symptoms that patients seem to have in the post-COVID setting. Little is known really about the optimal treatment, and I'll give you a taste of what we think could be beneficial, but we still don't have definitive data on that front. So what are the long-term effects of COVID? Some of this was discussed in the introduction today, so I'll go through it quickly. But the CDC, Centers for Disease Control in the United States, uses the term post-COVID conditions, or PCC, to define symptoms that patients have following a COVID infection that persist for a long period of time. Typically, when they use that term, they're referring to health issues that are present 4 weeks or longer after acute infection with SARS-CoV-2. Most individuals should recover fully within 4 weeks of developing that infection. And if they don't, they start to fall under this PCC umbrella. There are a number of different terms that people use to describe these symptoms under this umbrella. And this includes post-acute sequelae of COVID-19 or PASC, long COVID, or chronic COVID. These all refer to the same thing, and this can be a little bit confusing because we don't have a clear standard definition. Speaking to the fact that we don't have a standard definition is the fact that the UK National Institute for Health and Care Excellence and the WHO define long COVID a bit differently, also as was described at the beginning of this webinar. In their definition, they refer to the presence of symptoms 12 weeks after the acute COVID infection. And these symptoms should persist for at least 8 weeks and not have an alternative explanation. For the purposes of this talk today, I'm going to use the term PASC. This is the term that we typically use in our institution when we talk about these trials, so it's the term that's most familiar for me to use. Symptoms are variable and can be long-lived. So this is a figure from a study that was done by a group of researchers at Stanford University in California. And they have a very well-established post-COVID clinic where they follow patients for long periods of time. And in this figure, they depict the symptoms that patients in this clinic have Particularly, these are folks who've had symptoms for more than 6 months. So these are very long-lived symptoms. If you look at the right-hand portion of this bar graph, you can see the symptoms that are most prevalent are fatigue, PEM, which is post-exertional malaise, which I'll describe a little bit further, brain fog, or difficulty concentrating, difficulty thinking, unrefreshing sleep, and insomnia. These are some of the most common symptoms. And in this graph, they have about 105 participants that they surveyed. And you can see here, well over 90% of these individuals have some of these symptoms: fatigue, post-exertional malaise, so on and so forth. Just for reference, the severity score is here on the right. You can see those with more severe symptoms as scored in the survey have the darker representation in the bar graph. So you also get the sense that a lot of these individuals have very severe symptoms that can be life-altering. A lot of these individuals are no longer able to work if they are of an age where they are still in the workforce. These people have difficulty completing their daily tasks, tending to their families, and living the lives that they had prior to getting sick. I'm going to speak a little bit more today about the symptoms that are circled here in red, as these are the symptoms that are the most common. Before I move on to those specific phenotypes, I do want to point out the fact that it does seem that PASC, or long COVID, seems to be very similar to something that we term ME/CFS, or myalgic encephalomyelitis chronic fatigue syndrome. This is a condition that has been described for years now. Typically affects about 1% of the population, at least in the United States, believed to develop after infection, although an infectious trigger is not always identified in these individuals. And that infectious trigger is not always the same thing. Sometimes it seems to occur after a viral infection, sometimes after bacterial infection, can be related to tick-borne illness. There's no consistent rhyme or reason. And again, some individuals never have an infection history. There are 3 core symptoms that patients with ME/CFS have, and those include sleep disturbance. So these individuals will often have trouble falling asleep or staying asleep. And if they do get to sleep, they may not feel refreshed after sleep. So they could be in bed for a long time and still feel like they don't have energy to accomplish anything. Sort of tacking along with that is the fact that a lot of these patients have a lowered ability to do activities. A lot of this reduced endurance was not present before they became sick. And as I mentioned before, daily tasks become difficult. Going to the grocery store, picking up your kids from school, certainly going to work. And this fatigue is not relieved by sleep or rest. And then finally, these individuals often have post-exertional malaise, or PEM. And this is often described as almost a crash after doing some sort of physical or mental activity. And it doesn't have to be significant activity. It's not like these people go out and run a marathon and then feel very fatigued. It could be just doing a normal everyday task, and that leads sometimes to a crash afterwards that can take days to recover from. So it's a very dramatic phenotype that's not very well understood. But what we are learning is that this type of picture is not uncommon in patients with PASC or long COVID. And it seems like there might be some biological underpinnings that are shared between these conditions. Similar to PASC and long COVID, ME/CFS is usually diagnosed in individuals who are in the ages of 40 to 60, more common in women, just like PASC. And as I alluded to before, it's difficult to diagnose and is likely quite underdiagnosed in minority populations. So we really don't have a great sense of its true incidence. And this is exactly true in long COVID as well. And I know one of our speakers today will discuss this as well. As far as the suspected causes, there's some thinking that immune dysfunction could lead to this, and whether that is aberrant cytokine production, poor natural killer cell function or dysfunctional T cell activation, T cells either being too activated or not activated enough, could lead to immune system disarray leading to these symptoms. There's some thinking that an individual develops an abnormal stress response, so their cortisol levels might not be adequate. You can't diagnose it just by checking cortisol levels, but it seems that perhaps your innate response is just not balanced the way it should be. And there's some thought too that ME/CFS could be due to metabolic changes, maybe changes in mitochondrial function or things like that could lead to the body being in disarray. And there's no specific pharmacologic therapy that's been identified for ME/CFS. Oftentimes, physicians caring for these patients will try to tackle a very personalized, symptom-specific treatment plan. But again, because we don't fully understand what causes it, we don't have a magic bullet to cure it. And this is very, very similar to what we see in PASC. I think there are many similarities, and hopefully as we start to unravel this, we can tackle both conditions. So pivoting a bit to PASC, I wanted to talk about the 3 most common phenotypes that we see in patients. The first is exercise intolerance, and in its more severe form, post-exertional malaise, PEM, that I just defined previously. In these individuals, the most common symptoms are dyspnea and fatigue. And there can be several contributors to these symptoms. It's not that we know exactly what causes this in every patient. So certainly for a patient who had very severe COVID pneumonia, may have been hospitalized, could even have been on a ventilator, these individuals may have decline in lung function due to lung scarring that resulted from that severe disease. They may have residual parenchymal lung disease that you can appreciate on CT scan. They may have pulmonary function tests that are diminished compared to normal. And this is an obvious cause of what could be leading to dyspnea in this patient population. But it's important to note that the majority of individuals with PASC who have exercise intolerance actually have pretty normal pulmonary function tests, and they don't have a lot of residual parenchymal lung disease. So that's not the only answer here. Certainly, some of these patients could have deconditioning, right? If they were in the hospital for a long period of time, particularly if they were in the ICU. If they had other debilitating PASC-related symptoms that led to them reducing their normal activity levels, that could also lead to deconditioning and can lead to dyspnea and fatigue. So certainly that is a cause in some of these individuals, but it again doesn't explain the whole story. I think one finding that is most intriguing is that invasive cardiopulmonary exercise testing has revealed that individuals with PASC seem to have impaired peripheral oxygen uptake. So their VO2 max on these invasive CPETs is lower than it should be, but it's not due to the fact that their lungs don't work or their cardiac output is lower than normal. It actually appears that they have a reduced ability to take up oxygen in their peripheral muscles, and that leads to reduced exercise capacity. And it's unclear what causes that. Is that due to microcirculatory dysfunction with microvascular shunting? Is that, an autonomic nervous system related type problem? Is there a shift in the aerobic capacity of the muscle, the peripheral muscle? So usually it has a high aerobic capacity, but does it switch more to needing anaerobic metabolism? Is this due to mitochondrial changes? We don't know, but these are certainly some striking findings from these invasive CPETs that have been done. As implied by the name, invasive requires a fair bit of work, and it's not a simple test. So we don't have these on everybody, that's for sure. But we have learned some interesting things from the studies that have been done. And speaking to PEM, as I mentioned before, some patients have a very dramatic form of exercise intolerance in which they have significant worsening of their symptoms 12 to 48 hours after activity. And sometimes it can take days for them to recover. after this crash that I described before that is in the literature for patients with chronic fatigue syndrome, we may have patients that end up stuck in bed for days after they picked up their kids at school. So it's a pretty dramatic phenotype, and again, we don't really understand what causes it. As far as managing individuals with these conditions, there's thought that doing a tailored exercise program can be helpful, but that gets tricky, particularly when the phenotypes start to include things like PEM, because there's a very small sort of exercise envelope in which these individuals can work and not push themselves to the point of developing a crash. So it has to be a very patient-specific type program. Shifting gears a little bit, I wanted to talk a bit about sleep-related impairments. I think, I can say that I myself maybe initially had not enough respect for the importance of sleep. And this is one aspect of long COVID that I have been working on a fair bit myself. And it's clear that healthy sleep is central to physical and mental health, immune function, and well-being. And disturbed sleep, poor sleep, is associated with increased prevalence of cardiovascular disease, renal disease, mood disturbances like anxiety and depression, cognitive impairment. Poor sleep can lead to disruptions in autonomic function, can increase levels of inflammation, can increase levels of oxidative stress, can also cause metabolic derangements and neuroinflammation. And these are a lot of the ideas, the pathophysiologic concepts that have been implied in PASC as contributing to the phenotypes that we see. So people might already have some degree of autonomic dysfunction that has led to poor sleep, and then poor sleep then just sort of begets more trouble because the body is not in homeostasis and is not able to heal itself. In PASC specifically, it's thought that neuroinflammation may actually affect central brain centers that regulate sleep-wake patterns and circadian rhythmicity. It's also interesting to note that individuals with PASC and sleep disorders don't necessarily always have the same phenotype. There may be some individuals that start off by having more of a hypersomnia phenotype, so they want to sleep all the time. And then sometimes that can shift to more of an insomnia phenotype where they feel like they can't sleep at all. They can't get to sleep and they can't stay asleep. And we really don't understand why that happens, but it seems that there are disruptions to the central brain centers that regulate the sleep patterns. And again, as I mentioned before, these ongoing sleep disturbances sort of add fuel to the fire and may perpetuate PASC symptoms by contributing to all of the problems that we think underlie PASC in the first place. I mentioned some of the sleep disturbances already. So hypersomnia, feeling like you can't ever get enough sleep, falling asleep throughout the day. Insomnia, so difficulty falling asleep or staying asleep. Sleep-wake rhythm disturbance, so that is more of a circadian rhythm problem, where let's say you want to go to bed at 11 p.m., but you can't fall asleep until 3 a.m., and then you're shifted and you get up much later than you would like. It's important to note that many patients with PASC also are known to have obstructive sleep apnea or sleep-disordered breathing problems. This is also a little bit of a chicken or an egg problem. We think that patients with OSA likely have larger body habitus, which is a risk factor for more severe COVID. And perhaps those who have more severe disease, but not everyone, of course, with severe disease develops PASC, and certainly individuals with very mild cases of COVID can develop PASC. We don't think it's the case that COVID itself leads to the development of obstructive sleep apnea, but we do see that there are a lot of patients with long COVID PASC who have obstructive sleep apnea. Certainly OSA by itself leads to a heightened inflammatory state and trouble with oxidative stress and all of the things we discussed before. So diagnosing OSA in a patient with long COVID is probably one of the first steps that should be achieved before trying to address these other things. It's an easily intervenable approach, right? Do a sleep study, figure out if the patient would benefit from CPAP or some sort of oral appliance to help with their sleep disordered breathing. And that could by itself start to calm down the cascade that was triggered by the long COVID condition. Some individuals with PASC also report parasomnias and sleep-related movement disorders as well. So really the gamut of symptoms. The last phenotype that I want to touch upon is autonomic dysfunction. And the typical symptom that is reported is postural orthostatic tachycardia syndrome, or POTS. This is an abnormal increase in heart rate when a patient moves from lying down to standing up. So these individuals develop orthostatic intolerance and tachycardia. And it seems that it occurs in anywhere from 2 to 14% of patients with COVID-19. You know, it can be a rather debilitating symptom as well. Most of the time when we are trying to be productive in life and carry out the tasks that we need to do, we need to be upright. So the fact that this occurs to a substantial proportion of individuals with an acute COVID infection is certainly a problem. We don't know the precise cause of this either. Could it be autoimmune effect? Could it be invasion of the CNS by SARS-CoV-2? Could it be some sort of viral cytopathic effect on the autonomic nervous system? We really don't know. But the treatments right now for POTS that occurs in the setting of PASC is similar to the treatments that we have carried out for individuals who develop POTS for other reasons. And that includes volume expansion, increased fluid and salt intake, sometimes compression stockings on your legs or abdominal binders to just sort of hold the blood flow in there almost. And intravenous immunoglobulin IVIG. So I want to close with just a few outstanding questions. You know, who is at highest risk of developing PASC? Can we predict which individuals with acute COVID infection will go on to develop PASC? And as we've mentioned before, you know, there's not a clear correlation between the severity of your acute illness and your likelihood to develop these symptoms later on. There are data out there to suggest that vaccination is protective. We're trying to understand if different variants confer different risks of developing PASC. It's unclear, can you get PASC if you are reinfected? If you develop a recurrent COVID infection, let's say a year after your first, are you at risk of developing PASC then? As was mentioned at the outset of this webinar, does viral persistence contribute to these symptoms? Is this virus hiding out in our bodies, leading to, you know, a state of immune dysregulation? Are there phenotype-specific interventions that can alleviate these symptoms? I addressed some of the thinking that we have on that front before. And are the biological underpinnings the same for all phenotypes? So is the same thing leading to an individual developing POTS as someone who develops bad insomnia in the setting of long COVID? We really don't know. And then finally, regarding treatment considerations, I think the big question to start with is, are interventions that have been well established for other indications beneficial in patients with PASC? Certainly in the background, we need to try to understand the biological underpinning so we can develop more targeted treatments. But in the meantime, we can look at some of the standard treatment approaches that have been used for these symptoms and other conditions. So for example, cardiopulmonary rehabilitation has been shown to be beneficial in heart failure and chronic lung disease. So is that a place to start with people with exercise intolerance? We know that there are data to support the use of cognitive behavioral therapy for insomnia in individuals with sleep disturbance. So should we start with that type of behavioral intervention for people with sleep problems in the setting of PASC? And from a pharmacologic standpoint, do we use awake-promoting drugs like modafinil for individuals with hypersomnia and more of a narcolepsy phenotype? We know that it works in non-PASC related narcolepsy. Should we be using those things in patients with PASC as well? So that's where we're starting as we try to tackle this. And there's obviously a lot of biological work to be done in the background to try to understand this a bit more. our efforts in the United States to try to understand this include this Recover initiative. This is an NIH-sponsored initiative that was launched a few years ago. They have started enrolling individuals in a cohort study to just really try to get a better handle on what the symptoms of PASC are, what the phenotypes are, to try to understand from biological samples what we can from these individuals. And then there's a plan ultimately to move towards clinical trials to try to address treatments of some of these phenotypes. And with that, I'll turn it back to the moderator.
Salvador.
Muchas gracias, doctora.
Thank you so much, Doctor. It's been an excellent presentation, which started with the identifying the symptoms of the post-COVID and are related with an increase of fatigue, insomnia, malaise, and that you also mentioned a clinical characteristic that was identified in 1% of the population and that was related mostly to viral infections, bacterial infections, even tick disease, which provided a similar condition as post-COVID. Something important in your presentation is that this PEM, myalgic encephalitis, but you also mentioned that sleep disturbances with what you mentioned at the end with regards to the POTS that shows some changes in the patient and that attacks 2 to 14% of people that have been affected by COVID. And this condition is related or it is being associated to fatigue, tachycardia at rest. And at this moment, you are doing a number of research in trying to identify what are the causes related to this T-cell dysfunction, cytokine aberrations, or another change in the body. Dear Dr. Barbara, Christina, excellent presentation. Please remain in the room for the Q&A. Very kind.
Thank you.
Now, we will welcome Dr. Leonardo Tamariz. Dr. Leonardo Tamariz is professor at the University of Miami, the Division of Cardiology, physician of the Post-COVID Clinic of the Veterans Hospital, and director of the National Ethics Committee of the Veterans Health System. He is currently researching on prediction of cardiovascular diseases in asymptomatic patients and effect of COVID on the cardiovascular system. Welcome, dear Dr. Leonardo Tamariz, who will address the topic pathophysiology of post-COVID syndrome. The floor is yours. Thank you for the invitation. I would like to talk briefly about the pathophysiology, but I want to relate it with the phenotype and treatment that have already been mentioned. In this webinar, there are no disclosures. This is the financial contribution for the studies in our university. These are the goals for the next 15 minutes to present the different pathophysiological mechanisms associated to long COVID, relate these mechanisms to the clinical presentations and symptoms, and to talk about the possible treatment and how these mechanisms are related to treatment. At the end, I will present a unified theory as how we believe that long COVID is developed. I would not like to talk about rats and cells. I would like, in terms of mechanisms, I would like to talk about a patient that we recently saw in the veteran hospitals of our institution, the special typical patient that we see in our clinic, 45-year-old male with prevalent symptoms such as fatigue, dyspnea, memory issues, and joint pain. The SARS-CoV-2 infection occurred was 4 months ago, didn't require admission to the hospital, and there was no use of any treatment was provided. The dyspnea and fatigue persists in the initial infection, and the memory issues and joint pain and small, especially in the hands, started 2 months ago. He also reports a chronic back pain that in the last 2 months has increased. Right, you can see that nasaline test where we take the blood pressure and heart rate from minute 0 and minute 10, and you can clearly see that the blood pressure drops, but not as much to be defined of orthostatic hypotension, but it clearly there's an increase in pulse of more than 30 beats per minute that classifies this patient as POTS. This patient certainly has a PASC or prolonged COVID with persistent symptoms and new symptoms and worsening of symptoms according to the CDC, but it also classifies or fulfills a classification of WHO. And as you're going to see in the following slides, the symptoms that the patient has are not explained by an alternative diagnosis. These are the mechanisms that have been associated to long COVID, and it included squares that have no relationship, just to show you what are the mechanisms. We've spoken a little bit about them. I would like to indicate about talk about endothelial dysfunction, mitochondrial dysfunction, endothelial distress, the viral persistent inflammatory activation microclots, mast activation, the violence autonomic system, and viral reactivation. I will talk specifically about two and then provide a unified theory. Viral persistence is certainly one of the theories that is being most investigated in a very important study published in Nature 2022. To your left, you can see this chart, but it shows that there is a viral persistence in many tissues. In the nasopharynx, of course, as expected, but to find it in the aorta and the myocardium was not expected, and lymph nodes neither. The gut, kidneys, adrenal glands, in all those tissues, and even in the brain, we found the virus. It is true that this persistence is more frequent at the short term. We can see in the lower portion of the chart, but in patient 42, here to your right, you can see that there's still viral persistence 230 days after the patient had the infection and died because of autopsy. So there is viral persistence. And it's also, in addition to showing autopsy studies, even shown in plasma studies, finding spike protein in 60% of patients with prolonged COVID compared to 0% of control patients who recovered from COVID-19. I also would like to talk about autoimmunity. We did a small study where we demonstrated that many of the patients had anti-nuclear antibodies following the infection, and the levels of ANA were quite significant. Its dilution was 120, and the presence of these anti-nuclear antibodies was associated more joint pain in the hands and more severity of this joint pain. Others have found other autoantibodies such as B2 adrenal receptors or anti-angiotensin antibodies that is related to POTS, as we already mentioned. I think that the most important theory of long COVID is endothelial damage. We are doing experiments where we take the white cells of patients with long COVID, and we see this netosis, which it shows here, which is when a polymorphic nuclear opens and express its content in order to kill the foreign object, but unfortunately that also produces a capture of red cells, platelets, other white cells, and that produces a mild thrombosis that could cause vessel obstruction in the very small vessels, of course. So now I would like to show you the unified theory where we associated all these causes for that these patients present. First, a past infection of SARS-CoV-2 produces this persistence of viral particles, the persistence of the complete virus, and this causes a persistent immune activation that leads to generation of autoantibodies, and this persistent immune activation produces exhaustion of T cells, which produces a viral reactivation, and this persistent immune activation also produces mastocytes activation and a persistent elevation of cytokines. So persistent immune activation is certainly the key of the initial harm, the infection, because it also produces endothelial alteration, necrosis, and thrombosis, and the decrease of capillary flow and cell damage. This causes the symptoms that we try to show here. Cell mitochondrial damage associated with fatigue, this activation of mastocyte with concentration problems and mental fogging, pain and dysautonomy by autoantibodies and viral reactivation by the Epstein-Barr virus is associated to fatigue and pain. This slide cartoon where we show the cell damage with long COVID that starts before the cell. The autonomic system disbalance produces hypovolemia and vasoconstriction, and together with necrosis produces a decrease in capillary flow. This decrease in capillary flow associated also to a decrease of CO2 threshold and volume produces a decrease of oxygen and CO2 exchange at the cell level, and by having a low oxygen in the cell, there's an impact on the mitochondria, and the mitochondria does not operate adequately, it doesn't produce nitric oxide, and this produces an imbalance in the oxygen reduction of the cell, redox action in the cell, which is affected by C-reactive protein or IL-6 increase the superoxide inside the cell. This creates a vicious circle where there's a decrease of ATP produced by the. So I would like to go back to our patient that I showed you at the beginning and see what mechanism the patient present. We measure PCR, which was elevated, so we can say that there's a persistent immune activation. In this patient, we also had antinuclear antibodies, therefore there was also autoimmunity. Cortisol of this patient was also low, and we found that there was a reactivation of the Epstein-Barr virus, which we've seen in more than 80% of our patients. And the clinical relevance is somewhat difficult to explain it, as well as treatment. This patient also had endothelial dysfunction. We measure vascular reactivation following arterial occlusion, and the 1.2 VRI. This is a young patient, 45 years age. There's no reason to have endothelial dysfunction. I would like to correlate the mechanism tests that we do under clinical practice and the potential treatment. There are many work being done on viral persistence, very difficult to demonstrate that someone has viral persistence for the spiked antigen subunits, because we're not going to do biopsies in the tissues, and the potential treatment could be the use of antiviral. Dr. Wolf, immune activation, we measure it with ERC,
IL-6 and T cell number, and we also have activation panels of T cells. For research purposes, we use low dose of naltrexone because it's demonstrated that it decreases the production of cytokines, and we had good results with the use of naltrexone. The reason why we use this drug was mentioned because this is a very similar fatigue syndrome. The endothelial dysfunction or damage, the new that we're doing with this reactive hyperemia test, and what we're trying to do is have cardiovascular prevention and optimizing the cardiovascular biomarkers of the patients. Mastocyte activation, we use mastocyte stabilizers such as H1 blocker. In terms of thrombosis, we haven't done much because we haven't been able to measure these microclots, but we are sure that they exist in our patients because of endothelial dysfunction. And some of our patients have decided to go on anticoagulant therapy just with a previous thrombosis or history of thrombosis. Viral reactivation, something that we see frequently. We do a lot of Epstein-Barr viral reactivation and the PCR for the Epstein-Barr virus, but we haven't started studies for the treatment of this virus. Mitochondrial damage can be measured through uric acid in those molecules that can produce oxidative stress damage, and we measure osteopontine as mitochondrial marker, and we use antioxidant to improve mitochondria, and we have some preliminary results. Autonomic imbalance with this orthostatic hypotension test that lasts 10 minutes, and we're using vagal stimulation and amitriptyline. So I would like to conclude this brief presentation with there are many mechanisms that produce long COVID, and these mechanisms are related to symptoms. We can create phenotypes, and these mechanisms can demonstrate what can we treat patients, how can we treat patients. Thank you very much for your attention. Thank you, dear Dr. Leonardo. An excellent information with regards to how to respond at this moment with the current knowledge to the different issues. You presented a cause of a 45-year-old male who had an evident case of long COVID with some characteristics related to insomnia, fatigue, tachycardia, and other added problems. You also summarize what could the mechanism involved be for the presence of these signs and symptoms related to histochemical evidence and cell evidence of cell alterations. You did an explanation of how the human cell responds to the presence of virus, but also how it affects the endothelium to the presence of microclots or microthrombosis, and also impairment of the function of the endothelium, and also the sufficient irrigation and alterations of the vessels in the most important organs such as the heart and the brain and the kidney. And you also show us a comparative table of how for each of the signs and symptoms you have some treatments that are currently being used for the patients and are related to antivirals for the viral persistence and the immune activation through naltrexone, and the use of other drugs to treat hypercoagulation and also antioxidants for the improvement of the mitochondrial response in human body. Dr. Sen, thank you so much once again, and we invite you to remain in the room for the Q&A. Thank you. Now we will invite Dr. Ana Palacio. Dr. Ana Palacio is a professor at the University of Miami in the Public Health Department. She's a physician of she's the director of OCOP of prolonged COVID. In her research areas, the social determinants of health, chronic fatigue syndrome, and long COVID. Dear Dr. Ana Palacio, we thank you again, and we invite you for your presentation with regard to the social determinants of post-COVID patients. Can you hear me? Yes, go ahead. Well, first of all, thank you very much for the invitation. I have no disclosures. These are financial sources that Dr. Tamaris and I work together. The objective of my presentation is to define social determinants and the role in COVID-19 and in the vaccination against COVID-19, share how we collect social determinants at the University of Miami, and to show racial difference in long COVID and to propose some ideas of this biological process. What are social health determinants? WHO defined them as the conditions in which the population is born, grows, lives, works, gets old, including the role of health system. This has generated a lot of tension in recent years of the impact that social determinants have on health. And this organization, the country health talking rankings, did a systematic review trying to provide an answer to the net effect of social variables have. In this graph, they systematize the literature present at that time, and in yellow, you have the net effect of different areas in health events. As you can see in the second yellow, you see clinical management 20%. What do we mean by that? That when they took into consideration the different clinical interventions that we can do in a health system, that explained just 20% of the events, while the health behavior, such as tobacco, diet, exercise, and alcohol, had a 30% effect, and social factors such as education, employment, income, family support had a 40% impact, and the physical setting had a 10% impact. So as a result, what we can do in our clinic is just a 20% impact, and we have this other 30% of behavior, 30% of social factors where we don't have much possibility of intervening. So among the different health systems has started to look how to understand this and find a way to modify this variable. In our university, the first thing we did was to collect information. First thing we did is collect information based on the census and to add it to our clinical electronic record. In this slide, I show you one of the first efforts that we had to see the effect of these social variables on diabetes, and we included in the map all the values of HA1C that were 30,000 at that time, and then we calculated the average by neighborhood. And you can see that the larger the circle, the higher the A1C. You can see that there's a great disparity depending on neighborhood. Some neighborhoods have 7. These two south of the county, of Dade County, while here in this neighborhood where our hospital is located, the average is 11. And we compare that with the lowest and the best and worst diabetes profile, and we saw that social differences were remarkable. Salary in the neighborhood with the poorest diabetes control is much lower than the mean salary in the neighborhood that has the best diabetes control. And if you continue looking at the other variable, you see that the race distribution was quite different. There's much more crime in the neighborhood with poor control, less parks, more pollution. We found that there were different genetic polymorphism that has opened to many other types of research. Why am I telling this? Because we saw that this had a major impact in a chronic condition such as diabetes. We decided to collect self-reported information from the patients, and we drafted a questionnaire that the patients respond before their visit. And our university with its health system is private. People who come here have insurance, and we have almost 50,000 people that have responded to this survey, and we saw that the prevalence of self-reported social determinants was high. We see, for example, difficulties to pay utilities or medicines or food. In general, was 32%, and within minorities, 40 and 42% of people who come to our clinic have difficulties to pay these utilities. There was also a large amount of stress in 1/4 of the population. There was social isolation in 1/4 of the population, delay in medical care. We see that almost 1/3 had to delay their medical care more than 12 months to see a physician, and this was more frequent in minorities. So this made us continue with the evaluation of the impact of social determinants, and we created this dashboard that allowed us to have the variables and be able to correlate them with other clinical variables. And this is what we did when the COVID started. First thing we did was we realized that we started to report disparities in acute COVID, and this was very early, summer of 2020, where we decided to do this study. We used the social variable that we had already integrated that I showed you in the previous dashboard, and we overlapped them with the reported incident by the state by postal code. We entered the data of social determinants by postal code, both self-reported as well as census information, and the data from the state of Florida with regard to the COVID incidents that you can see in the neighborhood that had less income of $18,000, who with a higher financial strain, who have more social isolation, had 8 COVID cases per 1,000 inhabitants, much higher with compared to a neighborhood that has higher income, less financial strain, and less social isolation. And when we analyze all the neighborhoods, we found that this variable, financial strain, salary, and social isolation, were predictive of having a COVID case. That is, social determinants were very correlated with COVID. So we decided to evaluate what was the real prevalence of long COVID, and we start a process of screening. This process was carried out in the veteran hospitals and was done in several ways. First, we sent an electronic email with a screening survey to almost 3,000 people. Now we have close to 5,000 people. But at the time we did this analysis, we had this data and we had a response of 12%. Most of these people had symptoms of long COVID, and this perhaps motivated them to respond. So this response is probably a proxy to the percentage of people that may be suffering of long COVID. Then we wanted to test that perhaps the response could be better if we did it by regular mail, and we found that the response was at 25% when sent by regular mail. And then we made a phone call to 200 people who had a positive COVID test, and we found 50% of response. And with regards to the prevalence that we found in our, or in this small sample of 10 to 12% of people who indicated they had COVID and reported symptoms of long COVID. The audio is breaking up, I'm sorry.
Hola, doctora. Hemos perdido comunicación.
We lost the audio.
Déjame ver si me puedo comunicar con
Let me
ella.
see if I can call her.
Sí.
Oh, I think she's back. Yeah.
Bien.
Está,
think it's back.
está en mute.
I don't know what happened with my internet connection. My apologies. How far were you listening to my presentation?
La lámina anterior, por favor.
The previous slide, please. So I was telling you that once we completed the screening process and we realized that there was a incidence or prevalence of almost 12%, and in our hospital we had thousands of people with COVID, we decided we need to create a clinic that was a very complicated process from the administration point of view, and it was completed. Now we have the referral, the screening, where we send a screening questionnaire either by regular mail or email or text messaging or clinical referral. Then we have 3 questionnaires to establish symptoms of long COVID. We do an in-person evaluation for certain physical examination. And this test mentioned by Dr. Tamaris test the orthostatic tolerance with a 10-minute test standing up. We do diagnostic tests, and once we have that, we provide virtual follow-up in our clinic or specialized clinics. We find any target organ damage, and then we have a support group clinic that uses a holistic method where we pool nutrition ideas, mindfulness, respiratory techniques, respiration techniques, improving the environment profile, and many others. So our clinic currently has 3 general practitioners, 1 physical therapist, medical assistant, 2 coaches, and we do this type of evaluations on an individual fashion or virtual group evaluation. We use several modalities to try to accommodate patients who cannot have the energy to come to the hospital. And our model is a hybrid interdisciplinary clinic, virtual and on-site, that emphasizes the holistic treatment of the patient. In the screening process, we did find some interesting findings. Almost 12% of people are going to have symptoms. However, we had a question that indicates if you feel that you have recovered from acute COVID, but we also asked about symptoms to everyone. So this group was patients with and without COVID, all the ones that had a history of acute COVID, and the number of symptoms and were stratified by ethnicity and race, and we saw Hispanic and Blacks had more symptoms and more frequency in the screening population with fatigue, with these minorities. There was also a question about if they had sufficient energy to carry on their daily activities. And there we saw a disparity. There was less people telling that they had sufficient energy. But there was a part that I would like to emphasize. We have this question. If they had recovered from acute COVID, many people said yes, but we did ask about symptoms, and it was interesting that among the people that reported that they recovered, in whites, 0% had symptoms. However, between the Hispanic and Blacks, there was people who reported being recovered and had symptoms of long COVID. There was also a disparity that perhaps could have been a limitation of the question itself, or some misunderstanding, and people who reported having recovered, they do have symptoms, so that made us improve the way of to screening and ask modify the question to be more efficacious in identifying people who have prolonged COVID. Then we start the process of enrolling in our clinic, and these are the baseline characteristics. At this moment, we have 750 people, but at the time of this analysis, I think that we had approximately 300 patients. We have, this is a clinic in VA hospital. There's a minority of women. In our clinic, we see that females are overrepresented because these are VAs. The mean salary, we saw that it was lower income, and the social deprivation index was lower, and there's less people that have completed high school or university or college. The BMI and chronic diseases were more common, especially in people in the Black, but obesity and diabetes was also very prevalent in Hispanics compared to whites. So there we can start to see what are the determinants that are influencing in having worse acute events as well as worse chronic events. They have a different risk profile. With regards to symptoms that have been described in the previous presentations, we see that Hispanic and Blacks had more symptoms than whites, and they also had more previous infections. Being a minority predisposed them to have more than one COVID infections, and we saw a large disparity in fatigue. Blacks and Hispanics had much more fatigue. Here we're measuring people who had at least moderate fatigue, where the severity was higher in minorities. With regards to lab tests, we also found differences. We saw that cortisol was lower in minorities. It was more the anti-nuclear antibodies were positive in greater percentages in minorities. C-reactive protein was higher also. And the autonomy, we found that a large majority, once you do the orthostatic intolerance test or this Compass 31 questionnaire to try to evaluate this autonomy, we found that a great majority of patients have this condition, and this was more frequent in racial minorities. What can we do at this respect? I'm going to share a couple of things. which is what we're doing in order to mitigate both long COVID as well as racial and ethnic difference in long COVID. The first thing is vaccination. We have emerging data that vaccination prevents or attenuates long COVID. In this clinic, which is a clinic which offers special services to minorities, this serves 93,000 people. Here we did a pilot intervention to try to decrease this disparity in vaccination. We start to report that minorities didn't trust in vaccines and they had a rejection and less chance of being vaccinated. So this clinic decided to evaluate it in a pilot study where they promote and call those minority members to let them know that the vaccine was available. This clinic has a model with a lot of preventive medicine, and they see patients quite frequently. So despite we were in a pandemic and the clinics were closed, they did not, they continue operating and continue to see patients on site or by phone or virtual. And every time they saw them, they will explain about the vaccine. So down here, well, we can see that these were older people because they have Medicare, then over the age of 65, and they had a very common profile of chronic diseases with many comorbidities. The people that have social deprivation, this clinic serves people with social needs. But down here we see number of visits. You can see that in total, during the pandemic, they had an 12, average of 12 visits per year, once per month, and didn't change depending on race or ethnicity. There was a very proactive process to see the patient either by video, in person, or by phone. And the result of this effort of having this close contact with the patients and promoting the use of vaccine was that there were no disparities in vaccines in this population. You can see the bars are the Hispanic have more vaccines than whites. And in this table here, we see that one of the determinants for people to vaccine was the number of times that people were seen. The more frequent, the greater number of time that you spoke with a person, there was an increased likelihood of completing the vaccination schedule. So something that can be done is that reach these risk populations with health promoters or different type of campaigns, but to contact these populations at risk in promoting vaccine use and to create trust will increase vaccination. And the other thing we're doing is to create a clinic network to create models in areas where perhaps they don't have the resources for their own clinic. So we see a map of Florida. We're trying to create an effective model to provide systems throughout the Florida state by using a system where one center, the Miami Center, is going to be the hub. We can see patients virtually, and we're going to develop some specific skills in the or facilities in cities to coordinate, but there's no need of creating all the resources everywhere. We can share resources, trying to reach the largest number of patients that's possible. And this is our purpose for this year, to establish the largest number of clinics and to enroll a large amount of patients in a long COVID clinic. And finally, research. Here we also going to participate in a research network, practice-based research network, where they have clinics doing the same thing that we are doing and sharing resources, data, the joint investigation. And the first projects that we are going to do is to understand the role of social determinants and toxic exposures in long COVID, and to understand the treatment patterns what works, what doesn't work, what the patients think, and these patients are going to share their experience. We can socialize in forums like this one, share our experience, and offer treatments to patients in the quickest possible way. And with that, I reach my conclusions. Social determinants impact all chronic diseases, in particular long COVID. There are several ways to collect social information, either by census or self-reporting, and these social factors influence, and these racial differences that we see and impacts on the severity of the disease presentations of vulnerable populations. They specifically need to have programs that reach them and can offer timely treatment. Thank you very much for your attention. Excellent, Dr. Ana Palacios. A very good example of a study that you've organized in order to provide an answer to the long COVID problem. Interesting thing you mentioned is when you establish that in order to provide a response to a health issue, you have to establish determinants that you realize that in the case of the determinants for clinical management, regards to health access and the quality of service only represented 20% of the response for health for a chronic disease. More importance also was the social factors, behaviors related to education, employment, income, family health, which represented 40% of the determinants, 10% for the environment, and 20% or 30% related to health behavior like smoking, alcohol, and exercise. This first gave us way to the second element related to the studies that you have organized before COVID to determine how the chronic disease such as diabetes presents in differentiated populations by race, and you found that the worst indicators of risk were in blacks compared to whites. You also mentioned of how you saw the information between whites and blacks where they indicated their problems in different items that you explore, such as education, family income, economic pain, and in the case of the white race, all these factors for the presence of long COVID did not, they had a negative response, but following the question, you found evidence of symptoms that had not been considered. Finally, the proposal is to increase the scenario of care of long COVID and to identify them in the map of the city or the state of Florida, and also proposing an exchange of information and care related to improving the vaccination, with a fundamental element for the populations that do identify that are at high risk because of age and comorbidity. Dear Dr. Palacio, thank you very much for your lecture. And now we will continue with the next space. We're going to have a relaxing moment after these moments of learning and exchange of knowledge. It is essential to take some time to relax and start a mini session of physical exercise during teleworking. Our institution encourages the well-being of those who accompany us in this virtual session. In the next few minutes, we will exercise with an active pose
to stay healthy, combat stress, reduce work fatigue, and keep muscles flexible and healthy. Please go ahead with the active pause disrupt. There will be no interpretation during this active pause.
Sí, vamos a adelantarnos más bien y
Instead of that, we're going to move directly to the Q&A. We would like to greet all of those who have joined us from Bolivia, Chile, Colombia, Ecuador, Peru, Venezuela, especially the health personnel of the ministries of health of each one of our Andean countries. I will ask the speakers to start your videos. We're going to begin with the Q&A. The questions are going to be according to the order of presentations, and then we will have 1 minute of a final message to close. The first question is for Dr. Wolf. What is the risk of developing not only new variants, but new strains? And the second question, what will be the responses that will be priorities under that scenario? And the third question, in view that molnupiravir has already been used for other viral infections, what information do you have about side effects? Go ahead, Dr. Wolf.
Sure. Thank you. They're actually great questions. So in terms of variants and strains, I think it should be our expectation that new variants will continue to emerge and become more prominent. In order to outcompete previous variants, they have to be more fit. They have to modify and have a selection advantage over prior variants. And so we should expect that there'll be a natural drift similar to what we see with flu every year. I think in terms of whether or not they are relevant, it becomes incumbent upon all of our institutions to continue to monitor the sort of the balance between the number of infections and the severity. You know, I would expect that this will continue to fade into a less severe pathogen, but I don't know that for certain. And I think if there's a future where suddenly we see the beginning of an uptick again of, say, older adults becoming more unwell, then I think we have to go back, look at the variants that are there at that time, understand how effectively our vaccine matches might have been, or how long ago, frankly, that we last did a widespread vaccine campaign. We know that vaccine effectiveness wanes over time, and then reassess, in fact, whether or not we need to put in another intervention point. So I think you should absolutely expect variants to continue to drift, and we're going to come up with different names, and they're going to appear like things are changing. That's normal evolutionary pressure. But I don't think that in itself should be the concern. The concern is only if that translates to sudden spikes in the amount of illness or the severity of illness, like it did, for example, 15 months ago in Omicron. that's probably on health departments and public institutions to track that, to be honest. And hopefully we've all now got some pretty good institutions in place to be able to sort of have a sense of that, not only locally, but globally, frankly. In answer to the molnupiravir question, maybe let me start with a clarification. I put up a little data slide that looked at the drug sort of efficacy, if you will, against certain viruses that are not COVID. To be very clear, that is preclinical data for all of those other viruses. So the clinical data that we have is on COVID. And in COVID setting, actually, the drug's proven to be very safe. I think there's always been a concern because of the mechanism of action. It's a mutation accelerator. It accelerates the virus into being replication incompetent. Could that happen on human tissues? Could it be a threat for fetal development? Or could it be a threat for oncogenesis? Can it drive cancer development? And so that's now been looked at in, a lot of phase 4 data, and I don't think has proven to be a notable problem. It's interesting that the FDA sits teratogenicity sort of level for drug development, and with studies that got to that level, there was no signal for molnupiravir. In studies that were a little more rigid, there did appear to be a very minor teratogenic signal. So but that is not borne out to my reading in any sort of post-marketing evidence, and the drug's been used now widely for a couple of years. So I do think it seems very safe, doesn't have any of the drug interaction or tolerability concerns of other medicines. And I think because of its mechanism of action, true of the other antivirals as well, whatever drift we have with new variants has no bearing on the mechanism for which that works. And we've not seen mutations develop in the general community that render those antivirals ineffective yet. Important to keep checking, but so far that hasn't happened.
Muy amable, estimado doctor. Excelentes respuestas.
Excellent answers, dear doctor. And now we go to Dr. Barkauskas. The first question for you. What is the importance of a single clear definition and a common definition at the international level of long COVID? What mechanisms do we have to achieve a definition as such?
Thank you for that question. I think it's a wonderful question. I think until we are all clearly speaking about the same thing, it's going to be difficult to compare notes and share data from country to country if we classify an individual as having PASC or long COVID on different timeframes. I think in order to understand the global impact of long COVID, having a single definition that we can all stick to is going to be crucially important. Now, what mechanisms do we have to achieve that? That's a good question, and I don't know that I have the answer for that. Certainly it would be lovely for it to all fall under one umbrella, and whether that's the WHO, something with a global footprint, that would be wonderful. Now, with that said, we know that there is a WHO definition, and I also know that the definition that we use in some of our NIH work does not match that definition. So that gets a bit challenging to make sure that everybody's on the same page. So I don't have a perfect answer to that question, but it's a very good one.
Gracias, doctora.
Thank you, doctor. There is another question for you. What therapies or drugs have shown significant results for reduced severity of fatigue in patients with long COVID?
Another good question. And right now, there's not one specific drug that has been shown to reduce fatigue in long COVID. As I alluded to before, there's a push to start a trial to test an antiviral treatment in patients with long COVID to understand if tackling the hypothesis of viral persistence and ridding the body of any residual virus may improve symptoms. When that is complete, which will be some time from now, we'll have an answer to that question. But right now, there's not a specific pill that can be given that fixes the problem, unfortunately.
Y una tercera pregunta.
And a third question for you, dear doctor. According to the scientific evidence, what is association is with depressive disorders and long COVID?
That's a very good question as well. I don't know the numbers off the top of my head, but depression tracks very closely with many of the phenotypes that I presented. So for exercise intolerance, for example, if an individual is not able to do their normal tasks and lead the life that they used to lead, that is associated with significant depression. Similarly, if people are not sleeping well, if they have significant insomnia, they can't work because of their sleep disorders, that is associated with depression. And the same thing with autonomic dysfunction, right? I mean, all of these conditions and phenotypes significantly impair one's ability to lead the life that they would choose to do. And whenever that is impacted, depression certainly follows. So the rates are very high. I don't have a specific number though.
Muy amable, doctora Bárbara.
Very kind, Dr. For your response. Dr. Tamariz, are there any differences in the PDI-SC according to the patient's age? This is an important question. In our post-COVID clinic, we have marked differences between patients who have less than 65 and over 65 for several reasons. People over the age of 65 have more comorbidities such as diabetes and hypertension that are associated to endothelial dysfunction and immune activation. So that confuses the capacity of identifying if the symptoms are related to long COVID or are related to another disease, for example, heart disease. That is the reason why we perform lung and heart studies in the patients in a post-COVID clinic. A second question, it would be right to mention that there's a duality in the immune response against SARS-CoV-2, followed by another question, what research lines are a priority to understand this better in the clinical? Could you repeat the question, please? It would be right to indicate that there's a dual immune response against SARS-CoV-2, and followed by a question, what research lines are a priority to improve its understanding in the clinical actions? I don't know what do you mean with this duality, but I'll give you my opinion of what I understand with this question. I believe that it is key to investigate the T cell and B cell response that is quite different in these patients, especially because this process called of T cell fatigue. B cells are hyperactivated, and we have seen any fatigue in those cells, but in T cells, we've seen that, and that exhaustion or tiredness leads to patients who having a negative HIV test, they have opportunistic infection that we see in HIV, and we've seen them with long COVID. And a final question, dear Dr. Tamariz. Do you know if there are genetic factors that increase vulnerability to develop PASC? That's a very good question. I didn't spoke about genetic factors. Yes, Certainly, in the pandemic, we found that people with certain type of blood had more predisposition to get the disease. The Heidegger group in Germany demonstrated that the severity is associated to HTLA specific antigen, and therefore there is a genetic predisposition, but we haven't discovered it yet.
Muy amable.
Thank you.
Una pregunta para la doctora Palacio.
Question for Dr. Palacio.
El cambio sobre las determinantes sociales.
The change on social determinants.
El cambio sobre las determinantes sociales.
The change in long-term social determinants.
Largo plazo. Ante ello sería recomendable.
So would you recommend to include ethnic minorities or marginalized groups as a population with priority to have access to updated vaccines according to the new variables? Yes. There are more and more data emerging that the combination of vaccine or that the variants are changing, but people who had COVID more recently have less severity than those who had COVID with Delta variant and before vaccinations. And there are more studies that suggest that the vaccine protects the disease or the severity of the disease. So on the basis of how difficult it is in terms of management, diagnosis, and social economic consequences of a debilitating disease such as this one, I would suggest that these marginalized groups will be prioritized where there is a stronger impact on even their capacity of survival or possibility of work. They need to be prioritized for vaccination and study so we can find ways of preventing the disease in those groups. And a final question, what have been the most important challenges and resources applied for reducing the therapy dropouts in ethnic minorities? Well, my response, I don't know how relevant can it be for our countries. I'm from Ecuador, and I work in a VA hospital. In the VA hospital, they have resources, and there's a mission to find those vulnerable people. So when the VA's health system finds that there may be groups at risk, for example, people who live in rural areas or people who don't have access to some services, it immediately makes changes or policies to guarantee that these people receive the treatment that they need. I was giving you the example that many cities don't have a clinic for lost COVID or PAC, and they immediately activated a system of how other hospitals can at least virtually offer service to those populations who are unprotected. That, of course, is not feasible in many areas, not even inside the US. So my experience is that what we do is to create policies and look for service models and redistribute staff so we can serve the population at risk. That is what should happen in all the health systems, but not all health systems have the budget. But that would be the ideal, to redistribute efforts and use models that include some health promoters and different models to reach those populations at risk. Thank you, Dr. Palacios. We thank all the presenters for the excellent answers. I will ask very kindly each one of you, in 1 minute, leave us a final message or comment in the order of your interventions. Go ahead, Dr. Cameron.
I mean, I think my message would be an optimistic one. We're in a far better place than where we were 3 years ago. You know, the fact that we can be here having a really careful talk about long COVID, as complicated as it is, and as much research as needs to be done still, and we're not talking about our full hospitals and the mortality that we saw 3 years ago, thankfully, it's just huge. And I think we've established so many systems in place now to share data, to share research, and to sort of learn how we're working. That's a far better place than where we were 3 years ago. So I'd end on an optimistic note.
Muy amable,
I'm gonna-
doctor Wolf.
Sorry, go
Tenía
ahead.
un mensaje final.
Your final message, please.
Okay. I'm going to end on
Yeah.
a positive note as well. Obviously, long COVID is prevalent. It's a problem, and it really has destroyed the lives of many, many people. And that doesn't sound very positive, right? But I think the positive bit that can come of this is the fact that this now gives us a chance to really try to understand the biological underpinnings of these types of immune dysfunction states that I think other individuals have experienced even before COVID was a problem. And I hope that because we now have much more directed effort to try to address these questions, we will learn about these conditions, try to unravel them a bit more, and hopefully, find treatments that help folks with long COVID and people with conditions like myalgic encephalitis, chronic fatigue syndrome. Again, another debilitating disease. So hopefully this gives us a chance to learn more.
Muy amable, estimada doctora.
Thank you, dear Dr. Bartauskas.
Muchas gracias por su respuesta.
Thank you for your message.
Adelante, doctor.
Go ahead,
Tamariz.
Dr. Leonardo Tamariz.
Yo voy a dar un
I'm
mensaje
going to give
personal por mí.
a message for Anna on my behalf.
Otra reunión.
Her behalf, she had to go to another meeting.
Yo creo que
I think
si es que en
that
Latinoamérica se va a
if
establecer
in Latin America we're going to establish
ayuda a los
a
pacientes
system of help of people with long COVID,
fundamental que
I
se
think that it is
haga
very
educación.
important to
Ciertamente los
put it
pacientes
together with research.
tienen que tener
Certainly, the patients in Latin America will have some differences with the patients in the US. So
no pueden utilizar los mismos
you cannot use the same treatment.
tiene que ser más personalizado
This has to be more tailored and adapted to that setting.
se debe de
And
tener en cuenta los
we need to take into consideration the social determinants,
que se haga de
any effort that we do for long COVID in Latin America.
Muchas gracias, doctor. Y
Thank you,
por su
doctor.
intermedio, la doctora Palacio.
And to
Quiero
Dr.
reiterar,
Palacio too, I
estimados
would like to once again thank our
ponentes,
excellent speakers and to all the attendees who accompany us week after week, to the Andean Health Organization Hippolytan Agreement team, and to all of those who participate in this activity, which has been possible thanks to the commitment to Andean and Latin American integration. Now, I give the floor to Dr. María Carmen Calle, Executive Secretary of the Andean Health Organization, for the close of this webinar. Go ahead, Dr. Calle.
Muchísimas gracias, Lucho.
Thank you, Lucho. Well, my first words to thank the Dr. Cameron, Dr. Cristina, Dr. Leonardo, and Dr. Ana for sharing your knowledge and also what you are doing in your realities. Our realities are definitely different, but from Latin America, there's a lot of research, but we know that we still need many more things to do. Research is extremely important, but we are better than 3 years ago. But we also need to have clarity and the importance, and that's why from the Andean Health Organization, we have an important project of genomic surveillance in 4 countries. And that is why from the Andean Health Organization, on our monthly meetings with the national authorities of health, we
talk about this topic, and it is not the development of our six countries in regards of how they are dealing with long COVID. It's not the same, but these meetings allow us to exchange experiences and good practices to do things better. It's been a very good review. We talk about everything practically, and I think that we do need to continue studying. This is not the first time that we talk about long COVID in these 3 years of webinars. I think this is the fourth or fifth time, and we very well know that month after month, year after year, there are new research that are going to allow us to have a better, it's going to allow us to have better, try to deal with this in a more efficient way and more timely, the long COVID. I would like to make a comment that in our region, there's a lot of inequality in relation to social determinants. We're the more unequal, the region with more inequalities in the world, and that contributed that our region had more mortality and everything else that you already know. However, I think that we'll continue working so that all the evidence-based science update allows us better decision making from our governments so that we can achieve this right of the highest level health possible. Thank you very much for your time. I'll see you in our next webinar. That's going to be March 23 on Thursday at 5 p.m. We'll change switching time, visibilizing the health emergency of chronic renal disease, policies and intervention from the first level of care. Thank you very much and see you soon. Bye-bye. Thank you, Lucho. Thanks to the whole team. Thank you, Dr. Cameron, Dr.